we continue pretty much on time, and I will ask now Costa Herbert to come in. We thought it would be helpful to have, as part of our the spectrum of our presentations today, a presentation from a nursing perspective, since what would we be in the clinic without our nurses, and what would the patients be? So Costa was kind enough to agree. She is a long-term nurse here at our center, Hutch and the SCCA, University of Washington. She has been heavily involved in transplantation. She has taken on a lot of patient education activities, and is currently a supervisor. She may have additional functions. She can tell you herself. So Costa, thank you very much. We accommodated her timing such that she can celebrate with her son his birthday today. So thanks for doing it on his birthday. But please proceed.
Good afternoon, everyone. Thanks so much for having me. As Dr. Deeg mentioned, I have been a transplant nurse for some time, and one of my favorite things about the work I do is talking to patients, educating patients, and so this is something I'm really excited to participate in, even on my son's birthday. So thank you. Thanks for being here. I'm going to go ahead and share my screen. Okay, hope everyone can see. Can everyone see the slides okay? Maybe just give me a thumbs up. This is
Yes.
Great. The challenge of Zoom. Okay, so at the end of our talk today, we should be able to talk a little bit about side effects related to disease and treatment, interventions for fatigue, preparing for transplant, potential post-transplant complications, and palliative care considerations, which is something I'm quite passionate about. So just a quick reminder here, bone marrow is soft sponge-like tissue found in the center of most of your bones, especially your long bones, and it produces blood cells. So this is just kind of a reminder of the cascade here. So this is the what these cells turn into when they grow up. So you have your red blood cells, your platelets, and then all your different white blood cell lines here. And so when you have an issue with bone marrow and bone marrow failure, it's on one of these lines. So as many of you likely know, it means bone marrow failure means impaired production of blood cell lines. It can be acquired or inherited, so genetic or something that happens later in life, and cause abnormal bone marrow proliferation. And in addition to a decrease in blood cell lines, it can occur in 1, 2, or all 3 of your blood cell lines. And an involvement of 3 lines is called pancytopenia, where you don't have any counts on your platelets, your white blood cell, or your red blood cell line. So we'll just touch on anemia. It's probably something you're all pretty familiar with at this point. So I like this visual here of, here's kind of a blood sample with normal blood, and it's showing you the percentage of this that's red blood cells. Here's anemia, so you're seeing a decrease in the red blood cells, and then a polycythemia, which is an elevation of red blood cells. And depending on your center, they may measure hemoglobin or hematocrit, and even though they're different measures, they're both looking at what is the how much red blood cells do you have present? And, you know, the important thing to take away with anemia is that patient symptoms differ, and people can be quite symptomatic at different hematocrits. So someone at 28 could be symptomatic, where someone else can tolerate all the way down to 21% if you're looking at hematocrit with no symptoms. So some of the symptoms of fatigue, which are really important to pay attention to, are fatigue, weakness, shortness of breath, cold extremities, pale skin, irritability, irregular heartbeats. So some people can feel funny heartbeats, and chest pain. And then we can give red blood cell transfusions. There are some red blood cell growth factors which may be appropriate in some clinical settings. And it's kind of not intuitive, but activity also does seem to help with anemia as long as people are also taking adequate rest periods. People can get quite positional blood pressure changes when they're anemic, so just paying attention to that. And then, as I mentioned before, knowing what your own triggers are for knowing when you become symptomatic and needing red blood cells. So now to move on to another line, the platelet line. So low platelets is defined as thrombocytopenia, and it's lower than normal platelets. Normal platelet count is 150 to 400,000. And then symptom of low platelet count is bleeding or bruising. And you can see in the picture here that what platelets do is they go to the area of injury and they become activated and they facilitate clotting and they work to cover that area to heal. And what happens is blood vessels send a message to the platelets that there is an injury. So some things to keep in mind with platelets. Obviously, we have platelet transfusions as well. There's some new platelet growth factors out there, although I think the data is pretty limited on their efficacy. We do have our patients be fairly careful about anything that could cause bleeding. That includes any medication, such as your ibuprofen, Aleve, any medications that can make people prone to bleeding. We have them avoid strenuous exercise or weightlifting. Fall prevention is a big one. We really want patients not to fall in general, but it's even more critical with a low platelet count because the damage could be pretty severe. As the medical team and the patient, we plan for any procedures that a patient may need and what amount of platelets need to be present for that particular procedure and transfusing appropriately. And some patients, if they have a fairly large spleen as part of their disease process, it tends to eat up their platelets. And sometimes we can look at removing the spleen, although that's a fairly invasive surgery. So leukopenia is a decrease in your white blood cells, and white blood cells are infection fighting cells. About 40 to 70% of these are neutrophils, and they ingest bacteria and fungus. And unlike other white blood cells, they can travel in and out of vessels, which makes them fairly helpful. They also, this picture depicts how they find a cell, a foreigner, and they ingest it, and they cause death to that cell, and then they can spit out the cell content. So that's kind of one of their mechanisms of action. And a neutrophil count of less than 1,000 can be fairly critical. And symptoms of a low white blood cell count could be frequent infections and slow healing wounds. So in terms of treatment for low white blood cells, we can give white blood cell growth factors in certain scenarios. We do heavily educate patients on infection prevention and things to be aware of, things to avoid. Avoiding certain high-risk activities and avoiding any foodborne bacteria. So many of our patients, when their white blood cell count hits a certain amount, we have them start an immunosuppressed diet. And they are all on preventative medications, so antibiotics, antivirals, antifungals, things like that when their white blood cell count is low. And vaccinations pre-transplant, obviously, if they go into transplant. And then if people's white blood cell and immune system is robust enough, just staying on top of immunizations. So physical side effects of treatment that you may receive for bone marrow failure. These are pretty common across the board, even with your azacitidine and hypomethylating agents and different chemotherapy regimens. So nausea, vomiting, diarrhea, constipation, mucositis, lack of appetite, fatigue. And then other side effects that aren't talked about quite as much are distress, just the stress of going through a cancer diagnosis and all of the people involved in that. The adversity and role reversal is really important, especially if someone's been a caretaker to someone their entire life. And now the role is reversed and they're requiring the care. It can be a challenge and difficult to ask and receive that help. Change in identity, the health burden. So oftentimes people are quite worried on how this impacts their family and their loved ones. And then something else we'll spend a little bit of time talking about later is the financial burden or the financial toxicity. Toxicity sounds like a really severe word to use when talking about finances, but I think it's actually a very appropriate word to use because it's something we don't spend enough time talking about, and it should be thought of as a side effect related to cancer treatment, just like nausea, vomiting, diarrhea. So nausea, vomiting, we won't spend too much time talking about, but from a nurse's perspective, some of my tips are to take anti-nausea medication at the first sign of nausea, come up with a schedule for your antiemetics. Sometimes a combination of antiemetics works best for patients. And labeling them. So oftentimes patients, especially when they're overwhelmed and have a lot going on, they're confusing which medications do what. So just making sure you have a good understanding as to which medication is used for nausea. Eating more small frequent meals and avoiding anything fatty, heavy, spicy. And this is a big one, and we'll talk about it in a couple of different capacities as well, but keeping a log to identify any patterns is really helpful. So if you're going even 2 days without, a couple days without seeing your medical team, and you've had nausea and vomiting, or even up to a week or two without seeing them, it's really important to help us determine, are there any patterns? Are there any triggers? Did it happen when you woke up in the morning and were hungry, or after a big meal? Or so I think a log is really important to help you remember what was happening in that moment and help your medical team try to piece together if there are any contributing factors. Remaining hydrated, and then talk to your team about any other things that may be contributing. Same with diarrhea and constipation. I'm really big on a log. This is something I encourage my patients to keep for all kinds of things. I know it sounds cumbersome and people are so overwhelmed as it is, but even if you can jot down anything that was happening in that time period, it really helps us determine what the picture is when we're not seeing you. And then intravenous fluids may be needed for diarrhea replacement. Talking with your dietary or nutrition team if your center has one, and then reporting any changes in bowel movements to your team. Similar to nausea and vomiting, we can look at, are there any contributing medications or factors? And also if it's appropriate for your scenario, and if we've done the appropriate lab work to determine we can proceed this way, there may be some medication we can give to decrease both diarrhea and constipation. So mucositis, we won't spend too much time on, but it is a known side effect of multiple different chemotherapy regimens. Basically, it's just the breakdown of the cells inside your mouth because they're rapidly dividing cells. The main thing we do to help treat this are educate our patients how to make saline rinses at home and to keep their oral mucosa nice and moist as possible. So brushing and flossing. Some centers do have patients avoid brushing when their platelets are pretty low, but we find that it's appropriate to have patients brush their teeth with a soft bristle toothbrush as long as there's no pain or bleeding with that. Same with flossing. Mouthwashes seem like they would help for mucositis, but oftentimes they have the opposite effect and can dry out your mouth further. So unless it's prescribed by the team, we do have our patients avoid mouthwashes. So this is something else that I don't think we spend enough time as clinicians talking about. And I think that we're improving and spending more time talking about some of these other side effects, but cancer-related fatigue is huge. So my guess is many of you who are on this call have experienced cancer-related fatigue. And it's different than regular fatigue in that it's not relieved by rest or sleep. And multiple studies have shown that over 80% of patients undergoing chemotherapy experience fatigue. And of this group, 30% of them had daily fatigue. And this may be due to the disease itself or the treatment, or both. So this was a visual that I really liked here. As a nurse, is really important for me to remember. In clinic, we spend a lot of time talking about pain and nausea and vomiting. And this study is basically showing that of these patients surveyed, more significant to them than pain and nausea and even depression or feelings of low mood was fatigue. So definitely under-assessed. Because as clinicians, our practice is not perfect and we're all working on improving and taking the best care of our patients, but feel free to bring it up if you're struggling, with severe fatigue and you feel like you haven't talked about it enough with your team. So some interventions is we do try to have our patients limit sedating medications, make sure they're getting their rest at night, look at, are there any other underlying medical or lab issues? Fatigue is also not intuitive, that the more people are exercising, the less fatigue they do tend to have. We actually have a study at our center right now that has a control group of patients that are exercising at least 20 to 30 minutes a day, and then a control group doing what they normally do, which is just exercise when they feel up to it. And it's quite surprising how much of a decrease in fatigue the exercise group is having. But keeping in mind, patients do need to take rest breaks with that and naps and whatever stress reduction things they can do. That also helps with fatigue. And there's a significant amount of research showing that eating a balanced diet helps decrease fatigue as well. So financial toxicity was something we touched on earlier, but something that is huge. So one study actually found that about 25% of cancer patients had debt related to treatment, with a mean of about $26,000. So a very significant amount. And, we think about the direct costs, which is the treatment itself, the medications, the medical visits, the transportation, but there are indirect costs as well. So lost wages, relocation. We have patients move to Seattle all the time to receive treatment if they're not local. If they have young children, they have to often hire help to help with children, or if they don't have a loved one that can help take care of them, they often have to hire a caregiver. So there are several reasons why this is an issue. Make sure you're talking to your medical team, and same with fatigue. We're spending a little more time talking about it. I think there's a lot of opportunity for growth from a medical perspective on how often we bring this up. Some centers are starting to trial a financial toxicity worksheet. They're giving patients about once a month that just goes through a series of questions and helps us determine, is there any other way we can help this patient meet their financial needs? And ask if there are cost effective alternatives to your treatment. Many centers also have social workers or financial counselor that are really helpful. Employers sometimes have resources to help employees if you are still employed while you're receiving your treatment. And there's also funding available in patient advocacy groups as well. So moving on past side effects to patients that do require a stem cell or bone marrow transplant for their bone marrow failure. So what is transplant? It is transferring stem cells from a donor to a recipient. It can be a related or unrelated donor, and it may be the only cure for some diseases. And I put in parentheses imperfect because as Dr. Scott alluded to prior to this, it's not an easy treatment. So it's definitely not a decision that people make lightly. Donated cells engraft in the new patient and they create a new immune system. They also the donated cells can attack any remaining cancer cells. And factors to consider whether or not transplant is appropriate. It will be a decision between you and your medical team and your family. There'll be your disease status, your age, your health status, what donor availability is present, what type of family support you have, what type of caregiver support. So it's not an easy decision and not one we take lightly. So on the last slide, we mentioned how good of a match you have for your transplant being a determinant on whether or not transplant's appropriate. So just a quick slide of what is being matched. So it's called HLA matching, which is human leukocyte antigen. And I like this picture here. It just depicts, so you inherit genes from your biological mother and your biological father. And what you have is a combination of that. And if there were other children pictured here, they would have a different combination of these colors. So they're inherited in groups, and often ethnic groups share common chromosomal markers, which is often why people of a certain ethnicity end up with a donor of that same ethnicity. So the initial transplant workup, we will look at people's current functional status, what side effects do they have from their prior therapy. We'll perform a thorough physical exam, educate them on what to expect during transplant, including the role of their caregiver, and talk to them about the transplant process and time frame for recovery, and start talking about post-transplant complications. After transplant, we spend most of our time talking about symptom management, infectious complications. Infections can occur in all phases of recovery from transplant and are a major cause of post-transplant mortality. And the other two issues post-transplant can be graft versus host disease, as Dr. Scott spoke about a little bit, and then relapse. And that's even more so with reduced intensity conditioning. So what is graft versus host disease? So it's a systemic inflammatory condition primarily mediated by the transplanted immune system. So that's why it's the graft. So the new cells, they're attacking the body they were transplanted in. It can lead to severe multiple organ failure, and maybe acute, which is happening in the first 3 months post-transplant, or chronic, which is post 100 days. Some people can have acute and chronic if they're in that kind of day 80 to 100 post-transplant window. I find pretty fascinating that new research is coming out that the microbiome in our gastrointestinal tract seems to be playing a pretty major role in our immune system, as a lack of microbiome diversity is seen in graft versus host disease. So I'm sure we're going to be hearing more about this in the future, but just pretty fascinating stuff. In terms of infections, they can be fungal, bacterial, or viral post-transplant and pre-transplant if you have low counts and are susceptible as well. So the major sources are normal gastrointestinal flora and your central line catheters, which are often put in place for treatment for transplant. And the best way to mitigate that is teaching patients how to properly care for their central line. So making sure that you're caring for it as the team has instructed you to, keeping an eye on any signs of infection, and reporting anything to your team in real time, monitoring your temperature at least twice a day, and taking all the antifungal, antibiotics, and antivirals as ordered. So the last thing we'll talk about today is palliative care. I've been a nurse about 19 years, and this is something that patients tend to have a certain amount of anxiety talking about palliative care, because it's often confused with hospice or end-of-life care. So when we approach palliative care, people think, gosh, is this the end of it? Are we moving to hospice? Are there no more treatment options? And that is very much not the case. So palliative care is another layer of support, and they are focused on symptom relief and increased quality of life. So many centers, ours included, are moving towards getting a palliative care consult and involvement up front once patients are diagnosed with any type of cancer. Because this should really be viewed as complementing all of the treatments and therapies we provide instead of something we provide towards the end. And so this should be part of all cancer-related care. And then here's just a little model on how things are changing. So we're really trying to get, so at the left of the screen here is kind of where people are diagnosed. And all this is showing is we're trying to get palliative care involved much earlier, right? Really basically at the time of diagnosis. So if you hear your center or your team ask you about that, it's not because it's a hospice thing, it's because they're another level of support to advocate for you and advocate for your quality of life and things that you're passionate about. So with that, I'm at the end of what I had for you today. And I think, as Dr. Scott said, we're going to take questions later.